we often will see progression before or as a sole site of loss of control because very often because our treatments, at least historically, were not getting into what we call the central nervous system, which is basically the compartment where the brain is. And so we care about that because it's become an issue of vulnerability that has been heightened as we have people potentially living for years and years, but having this emerge as a vulnerability. And then secondly, our newer agents are actually able to treat this more effectively than ever before. So I don't want to get too personal about what people have received. Why don't we start with who is worried about or fearful of brain radiation? And that's people, particularly whole brain radiation. How about stereotactic or focal radiation? Okay. So certainly over the last decade or so, we have had a revolution where more patients are able to get focal radiation, what's called stereotactic radiosurgery or gamma knife, and that has been an improvement since a lot of people are, both docs and patients, are a lot less fearful of radiating a few focal areas of a few millimeters rather than the whole brain, which was historically what we did up until not too long ago. But one question is, how do patients do? And you've seen a few of these so-called Kaplan-Meier curves, which is starting with 100% of people doing well, and then over time, as you move from left to right, how many people are declining and not doing as well, and as the curves go down, it's not as good. And what you can see is in this now just a couple or 3 years old summary of how patients did, we were seeing that the patients who started with brain metastases and were treated with the pills, with EGFR inhibitors up front, were doing less well than the people who got radiosurgery, the focal radiation, or brain radiation. This is just looking at the cumulative incidence of brain metastases, so kind of the flip side of that. And this led to some growing concern that, okay, well, maybe by starting with the pills up front, we are doing a disservice to patients if they are actually not living as long. But I think it's important to have the caveat that this is really data with older EGFR inhibitors. And we do have a long history of treating with Iressa, Gefitinib, and Tarceva, Erlotinib. They were better than chemo probably, and certainly better than nothing for the brain, but they don't get into the brain very well. And so this is really judging against something that is becoming increasingly obsolete. We also had a little bit of data, and people have historically said, well, Xalkori or Crizotinib for ALK positive is not effective in the brain, but when you compare Xalkori to chemotherapy, it's better. And that's really not that great. But you could see increasingly encouraging results in patients who got second-generation ALK inhibitors. So this is an area where ALK has really led the field, and we saw multiple ALK inhibitors that are now routinely used show that they had good brain responses. And this, again, people are increasingly seeing these waterfall plots, and you know that downward bars are good, and the more downward they are, the better the response. Lots and lots of these brain lesions are responding very well, whether patients had received prior radiation to the brain or not, with now a second-generation agent, Alecensa. Similar results with Xalkori-treated patients who got Brigatinib. So these second-generation agents are just doing a very good job with response rates, the proportion of patients whose brain lesions are shrinking in the 50, 60, 70% range or so. And this is not large numbers of patients, and we don't really have extremely clear grading systems for this, but it's been a very clear recurring theme that now that you're in the second generation agents, we're seeing as a general rule that we have much more confidence that these lesions are going to respond. And here, this is called the ALEX trial that many of you are familiar with. It's second generation Alecensa versus Xalkori, first generation Crizotinib. Way better efficacy overall with the second generation agent looking in the body, but in the brain as well. Way better control in the brain with Alecensa, much lower risk of new brain disease developing. Similarly, this is just looking at response rates in the trial and showing that that was looking at prevention of new disease developing. This is looking at the responses of brain lesions that were there, responding way more likely with Alectinib than Crizotinib. It's a very clear, concise, consistent theme. We're also seeing that with Brigatinib. Here are data for intracranial disease and progression-free survival with Brigatinib, far better than with Crizotinib. Response rates of brain metastases, 67% versus 17%. So this is just something that has made us increasingly confident that we don't need to reflexively turn to our radiation oncologists to radiate all of the disease in patients, at least with ALK-positive cancer. We're also seeing that with lorlatinib, very good efficacy of here brain lesions. And now we have some good data with EGFR-based therapy, and I'd shown this in the EGFR breakout, but for others, this is looking at the third-generation agent Tagrisso or Osimertinib versus first-generation agents, Iressa or Tarceva, showing that progression in the brain way less likely in the patients who were on Tagrisso at the time compared to an active but not as effective first-generation agent, both in the body and in the brain. So rates of progression in body and brain are much less favorable in the patients who are on first-generation agents. And looking at how likely these were to respond, we saw a lot more brain lesions responding and a lot more shrinkage in the recipients of the Tagrisso. And that's also the case. That was one EGFR inhibitor versus another. It's even more pronounced when you're talking about Tagrisso versus standard chemotherapy. This was second line in patients with T790M mutations, and again, a very clear victor here. So it is a really quite consistent theme. One other issue is we've become more confident that our better, newer EGFR inhibitors and ALK inhibitors and probably ROS inhibitors as well will do the job. What about for other people? And that is not as clear. Basically, even though we have historically written off chemo as not effective, the response rates in the brain are pretty comparable to the response rates in the body, but that's 15 or 20%. It's just nothing that we can be very confident about for chemo alone. As a general principle, immunotherapy can work in the brain, but it's not as well studied. As you can see, this is a retrospective review just showing that about a quarter of the patients with brain metastases were doing well on immunotherapy. We're starting to look at this more, but as Helena just mentioned, in patients who are not as likely to do well on immunotherapy, that is, patients with a driver mutation, I would not have that much optimism that immunotherapy is going to work well in the brain. And so for people who don't have a driver mutation, I think it is very reasonable to cautiously follow now without immediately going to radiation. The difference is nowadays, if you have someone with an EGFR mutation or ALK rearrangement, you can be optimistic that it is far more likely than not that you'll be able to control disease in the brain, shrink existing lesions for a very long time with these newer targeted therapies that may apply to immunotherapy. And so this is a setting where the driver mutation world is kind of leading the charge and changing our mindset that we need to go in automatically, reflexively, and presume that we have to use local therapies like radiation to do the job in the brain. That there can be, if you have a good therapy that works very well outside the brain, it might do a very good job in treating within the brain as well. Maybe not forever, but for as long as we can keep patients from needing to get any of these things, it's probably a very good thing to forestall that. Because we do have, one of the issues we have just historically, especially with whole brain radiation, is if the job was just to temporize, for a few months, that's fine. But fortunately, we have more people living years rather than months. Good for everybody. But that gives us more of an opportunity to see the long-term side effects of brain radiation that we never had to worry about before because we weren't doing that well. And now, fortunately, we do have people living long enough that we need to be thoughtful about preserving the brain as much as we can. So that's the general principle of where we are now, but it's especially relevant for patients with driver mutations where we have many more effective tools to treat that than just than radiation automatically as our first choice. Thanks very much.